This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital, Pittsburgh, in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We are coming to you again with your favorite topic, something you probably haven't heard about or read about in a few days, COVID-19. We are going to try to dissect out how COVID-19 and kids function in terms of their role as spreaders of the virus. We're going to look at the data and the information that is currently published and see how this works. So to do that, I couldn't think of a better guest than my current guest, who was gracious enough to give her time for us, Dr. Megan Culler Freeman. Dr. Freeman is a MD, Ph.D., and currently a senior pediatric infectious disease fellow here at UPMC Children's Hospital, Pittsburgh. She completed her MD and Ph.D. degrees at Vanderbilt University, where she earned her Ph.D. studying coronaviruses in the laboratory of Mark Dennison. She's one of our few, if only, I think, coronavirus expert in Pittsburgh. She has multiple publications in the field and is author of the coronavirus chapter in the most recent edition of Nelson's Pediatrics. Her current research interests include pathogenesis and cell biology of RNA viruses and advanced tissue modeling, with a current focus on enterovirus D68, the hypothesized cause of acute flaccid myelitis in children. So, Megan, thank you very much for joining us again today.
Happy to be here, Tony. Thanks for having me.
Oh, sure. Now, let's get our paperwork out of the way. I will do my disclosure, and then you may go. I have nothing to disclose.
I also have nothing to disclose.
All right. So now we have a few articles we're going to go through, but I'm going to warn you guys from the beginning. If you're expecting definitive answers to solve all of the problems with COVID and spreading in children, we're going to disappoint you because the data is everywhere and all over the place and not clear really much at all. So the first paper that Megan and I are going to talk about is COVID-19 in children and the dynamics of infections in families. This was published in Pediatrics, August of 2020, and it's Dr. Clara Posfay-Barb and Naomi Wagner et al. And I'm going to do my usual, if I butcher anybody's name, it's accidental. I do apologize. I'm not sure how to pronounce it. So this was a paper published in Pediatrics, and it's a pre-publication that we found, which means it has not been fully vetted and has not been fully peer-reviewed, which is unfortunately a lot of what we're seeing with COVID is that because of the pandemic, people are releasing these articles online before they've been peer-reviewed. So the article may change by the time it actually gets published, at least slightly. But this talks about, and this is from Geneva, Switzerland, the study was done in, and it really goes into most pediatric cases were described inside familial clusters, and there was no documentation of child-to-child or child-to-adult transmission before they published this. So this paper describes the clinical presentation of the first 40 pediatric COVID-19 cases in their city and the dynamics of their familial clusters. This was done, like we said, in Geneva, Switzerland from March 10th to April 10th, 2020. And the diagnostic test, the mechanism they used was the nasopharyngeal swab, and which they used reverse transcription PCR. The data comparison was just a chi-square to compare the data. The total number of patients that they brought in was 4,310 with SARS-CoV-2 in that time. Only 40 were less than 16 years old, that's 0.9%, and one of the 40 was excluded because of the inability to do phone follow-up. And if I'm not mistaken, I want to make sure I get this right. This was a epidemiologic study where they looked at the data afterwards. using their databases.
That's correct. And I also think that after they had these 40 identified PCR positive children, the way that they obtained the information about who got sick first in the family was to call the family, follow up, and rely on the family's recall as to who developed symptoms before anyone else in the family.
Yes. And if you have kids or you're an aunt or uncle and listening, or you're just a person, if I asked you between your group of friends who got sick first, there's going to be some recall bias. There's going to be some mistakes in that. The comorbidities of the kid were interesting, of the children. So 29 of them, or 74%, were previously healthy. 10% had asthma, 8% had diabetes, 5% were obese, 5% were of premature birth, 3% had hypertension. 7 of the 40 were hospitalized, which is 18%, and the median duration there was 3 days. And the reason for those admissions, 2 of them was surveillance for non-hypoxemic viral pneumonia, and 2 were fever without source. 1 was Alti, which I assumed we had replaced with Brew, but maybe in Switzerland they still use Alti, or maybe just that's how it's coded. 1 was a sepsis-like event, and 1, both parents had severe COVID cases, so the child was just admitted with POSI symptoms and observed, but really nothing else. This is similar to what we would do in the States in terms of admitting kids, viral non-hypoxemic pneumonia who had COVID, just to observe. No patient, none of the children needed PICU or NICU or any medication specific for SARS-CoV-2, which they talked about in the paper. So the 32 kids who were not admitted were all managed as outpatients, and all of the 40 children had a complete resolution of symptoms by day 7 after diagnosis. And for those who are listening at home, now Dr. Freeman just did grand rounds at UPMC, Children's Hospital of Pittsburgh, this morning and is joining us this afternoon, so she's been busy today. But one of the things you brought up in your grand rounds is, since we're talking about now that all these kids resolved, and we brought it up a little bit before the show, was that the case fatality rate for children with COVID-19 has been extremely low. Is that right?
That's right, especially in acute disease. So this is not counting anyone that has had the multi-system inflammatory syndrome, MIS-C, but specifically for kids with acute infection, the case fatality rate that was reported on the greatest number of cases that had been studied, which was around 3,500, was only 0.1%. So there are some pediatric deaths, and they're often described as having comorbidities, but that unfortunately was not delved into any further in that study.
That's great. And then they go into their familial clusters, and they say adult household contacts were suspected or confirmed with COVID before the study child, and this is again is by phone recall in 79% of the cases, which is 31 of the 39. And they say in only 8%, or 3 of the 39 cases, the child was the index case of the household, and the child developed symptoms before anyone else. And 85% of the adult household contacts of the children, or 75 out of 88 adults, developed symptoms at some point, compared with 43% of the pediatric household cases. So there's 23 pediatric household cases of the children who got COVID. Only 10 of those 23 developed symptoms. So a much higher percentage of adults, 85%, would develop symptoms versus kids. And that specific fact of children not getting COVID as much when exposed has shown up in the literature a few times.
It has. It's confounded a little bit by, certainly in this situation, they were looking at households where children specifically had been ill. I still think that we're probably missing a lot of children in our counts because of their asymptomatic or mild presentations. It makes them less likely to be swabbed. But if they live in a household where mom and dad are known to have COVID, they're more likely to be swabbed as the children. So I think there's a bit of bias there in the amount of reporting that we're able to do.
That's great. And 92%, and this part was, I brought this up to my wife. 92% of the mothers, or 36 of 39 mothers, developed symptoms, compared with 75% of the fathers, or 24 out of 32. And that was almost statistically significant, p-value of 0.04.
Just tells you who's wiping the noses and who's bringing the
Yes,
soup, Tony.
yes, yes, it does. I mean, this is in Switzerland too, but it's yes, it does. Total, total of the study, table one of the study discusses presentation of kids, and the mean age was roughly 11.1 years, and it ranged from 5.7 to 14.5. The most common symptoms of the children in this study were cough and fever occurred in 67%, and then rhinorrhea was in 64%, and headache and sore throat were in 36% respectively. So 56 and 36. Sorry, headache was 56% of the patients, and sore throat was 36%. So, and that's what's terrifying for the fall. Because if I said to you, a child has sore throat, fever, cough, and a runny nose, and it's October, you would say everybody has that. That's really not that concerning.
And I don't expect that to change this year. You know, they had BioFire, who makes a multiplex PCR for a respiratory viral panel, has a website where you can look and see what results they've gotten over time. And it's a really interesting chart that shows kind of the distribution of all of the respiratory viruses. And then extreme closure and social distancing happens in March, and all of the circulation of all of those viruses falls off a cliff. But it's started to trickle up again as we've started to move about like normal. And I don't anticipate that that's going to change just because this is out and about.
Yeah, it's that's what's yeah, and I just hope we have uh, our our logistics will keep up and be able to have enough testing for everybody, because that's going to be the issue. Everyone's going to get a regular virus and be tested for COVID this year.
For sure.
And then overwhelmingly, in terms of what diagnosis they received, remember most of these kids were treated as an outpatient. 69% received diagnosis of upper respiratory tract infection. Um, in the study, they brought up the French epidemiologic study of a 9-year-old boy with respiratory symptoms associated with both all three, picornavirus, flu A, and SARS CoV-2 infection. He was found to have exposed 80 classmates at 3 schools. Then no secondary contacts became infected despite numerous influenza infections within the schools, which meant that that there was the environment conducive to respiratory viruses being passed, because those kids got flu, but nobody got COVID. And there are a couple other studies we're going to go through that are these epidemiologic, this kid got COVID and was around everybody, and none of his or her friends got COVID. And that's what we see a lot of with these things. This particular study, to me, Megan, the only thing I pulled from it is if a child gets COVID in a house, the parents are probably going to get it, and the siblings may get it.
Yes and no. So I think the figure that's really important to discuss is, I mean, it's the only figure in the paper, but it's figure 1. And essentially, they've gone through and detailed through these phone call logs each and every positive patient that they were able to get a hold of. So that's 39 patients. And for each of those patients, they cataloged in the family for each of the family members who got sick and who got sick first or who got sick after the child. And so it took me a second to kind of understand what we were looking at, but that's essentially the take home. So any of the little red squares are that person was ill after the child presented with symptoms. One of the troubles, though, with this paper is there are 1, 2, 3, 4, about 15 or so families where there is a red square, which means that somebody got sick after the child. And not all of those red squared persons were tested for COVID. So some of them are question marks. And some of them, even though they did test positive for COVID, were not counted if another member of the family also had COVID in addition to the child. So if, for example, we knew that mom had COVID and then child gets symptoms and then dad gets symptoms after the child, that was not counted as a definite child transmission because you don't know if the virus came from the child or the mom. So I completely applaud like the amount of work that this took to do. And I think the take home is it is possible for children to transmit coronavirus. It probably doesn't happen as often as it does either adult to children or adult to adult. But I think the theme of this podcast today is that we're still learning about it, but it's certainly not impossible. The other thing that's a little bit hard is because the incubation period is so long, you can develop symptoms anywhere from 0 to 14 days post your exposure. So, coming up with who developed symptoms before whom doesn't necessarily tell you who got infected first, but it's kind of the best we can do.
Yeah, that's a tough one. Thank you for that. That's a great, I didn't go in that table well. That was wonderful. Thank you.
Yeah, sure.
Now, the next paper we're going to talk about. This is another pre-publication release. This is a COVID-19. This is a commentary on the previous article we just went through. This is called COVID-19 Transmission in Children and Child's Not to Blame. This paper, the reason I liked it, it cited other epidemiologic cases, which suggests that transmission in schools they suggest that transmission may be less important than initially feared from schools. Now, how right that is, I'm not sure. They go through the French Alps paper, which I just kind of described to you, and that was by Danis et al., Cluster of Coronavirus Diagnosis 2019, and the French Alps 2020 in Clinical Infectious Diseases, an official publication of IDSA. And this, they went into a little bit more. It was a 9-year-old male, so the age is important because of the South Korean study. And we talked about that they had 3 viruses, and and he was exposed to over 80 classmates at 3 schools. Again, they're going skiing in the Alps. Why not? And then there was no secondary contacts became infected despite numerous influenza infections. So the only thing I liked about this paper, because it was just a commentary in the previous paper saying how important the work it is that it brought up those other epidemiologic cases and talked about them a bit more. That's all I took from that. Am I missing anything?
No, I completely agree. It's just so hard to interpret these when, it was one boy that had a viral infection. And while it's great that he didn't transmit to others, you don't know that his biology is exactly the same as any other boy that went skiing in the French Alps and was infected with COVID. So these studies, it's often hard to get this kind of negative data published in the literature, but I feel like, especially around this topic, it's really important to know who is able to transmit and who isn't. So I definitely think that this was a great point that this paper raised. And is a little bit encouraging when we think about going back to school. But I think it's also one of those situations that the absence of evidence is not the evidence of absence.
Yeah. And the other thing that struck me was skiing. I've taken my kids snowboarding. They don't like skiing. It's not a very communicative sport. I mean, go ahead.
You're not doing huddles on the mountain.
No, you're on your own. You're going down the mountain. You're getting back up. You're going back up. At the end of the day, you have French fries in the lodge. If your kids, probably French fries in the soda. So there's that aspect of it. But the rest of the day, it's a very individualized sport, similar to golf, similar to kind of tennis.
And it's outside, which we
It's out.
know that the amount of ventilation and a slight cross breeze can really be helpful as far as decreasing the amount of transmissible events.
Now, we're not saying everyone with COVID should go skiing. We're just talking about that paper. All right, the next one we're talking about is no evidence of secondary transmission of COVID-19 from children attending school in Ireland, 2020. This was Laura Heavey, Geraldine Casey, and C.R. Kelly et al. And this was in the European Surveillance, May 28th, 2020. This was a paper which gave the results of a contact tracing, a proper contact tracing done on 6 people in Ireland. And what they said was, it's at this particular school, the children went to Italy for vacation. And when they came back, shortly thereafter, there was an outbreak of COVID. And this was right before it looks like they shut the school down completely. So for that brief period of time, they found 6 people within the school, 3 kids and 3 adults. The children's ages were 10 to 15 years old. The adults were over 18 who got infected. None of them were infected in the school setting. One was travel related. 3 were part of a single household outbreak. 1 was a close contact with a recreational sense, whatever that meant. I didn't know what recreational sense meant. And they wanted to look at those children and adults who were in the school. They think after they were infected, how did they spread the virus? That's kind of what I took as what they were looking at. Every of the 6 cases they looked at, 3 kids, 3 adults, every case was symptomatic except 1 pediatric case was asymptomatic. So only 2 of the kids were symptomatic. They contact traced and identified 1,155 contacts of the 6 cases. They stated that they were exposed to sports lessons, music lessons, including woodwind instruments, and choir practice for religious ceremony, which actually involved a number of schools mixing in a church environment. There was 1,001 child contacts of the 6 cases, and there were no confirmed cases of COVID-19 from those contacts. None in the school setting either. In fact, when you look at the entire table, they only have one table. All the infected cases, the 3 kids and the 3 adults, they only seem to infect 2 other adults in a non-school setting. Now, what they called close contact, this is something I found interesting. Close contacts, once they identified the kids that were positive, and the adults, close contacts were advised to restrict movement and underwent active surveillance with daily contact from public health monitoring for symptoms until 14 days from last known exposure to the case. And then casual contacts to just monitor for symptoms were asked to physically distance, do hand hygiene, and cough etiquette. And it was not possible to ascertain exact numbers of symptomatic contacts who were tested from records. However, extensive testing were done. So they couldn't figure out everyone these kids were in contact, but they couldn't test everyone the kids were in contact with, only the symptomatic patients, which I think is important for when you look at the South Korean paper where they tested everybody. So what their takeaway is from this epidemiologic study as well is that school's a low risk setting. But one of my issues with this one was, again, they didn't look for asymptomatic positives to see if they were passed and then created the outbreak that did happen in Ireland.
Yeah, and it would be difficult to do that without being able to test everyone, just like you're saying. The other thing that kind of struck me about this paper is they go through and specifically describe how many contacts the children versus the adults have, and the kids in this study, each one had over 150 contacts with other people, and one of them had 475 contacts at school alone, which is an incredible number of people to have to then go contact trace, ask about symptoms, test. But that's what we're looking ahead to when we think about going back to school. The adults, on the other hand, had less than 100 contacts each. Which I think is just an important note about kind of the social activity of kids versus the social activity of adults, and how, since we do know that kids can spread, it could just be an exponential problem when we have more data. There's just so much more that we have to learn.
Yeah, and I like that they brought up the kids were in sports practices and choir practices and orchestra practices. All these things we're worried about, and they didn't spread it. But again, without testing everyone, it's just so hard. All right, our next study. We're plowing through this. Is great. These epidemiologic studies I found to be easier than the typical prospective randomized controlled trials. You have a lot more analysis to weed your way through.
It's good. It gives us a chance to cover all of the ones that are out there.
Yes. So the next one is SARS-CoV-2 antibody prevalence in a large school community subject to a COVID-19 outbreak, a cross-sectional study. This is by Dr. Juan Pablo Torres et al. And this was in Chile, the country Chile. And this was in March 13th, 2020. There were 58 confirmed cases in all of Chile. 2 of those 58 were in this particular school that they're looking at. And the Chilean Ministry of Health quarantined the whole school community. So then the week of March 4th, 2020, there was a parent-teacher meetings which were held nearly every evening that week. And one of the 2 positive contacts was at almost every single meeting. And as of April 6th, so about a month later, 2020, there were 52 school community members who were positive for SARS-CoV-2 with 1 death. The breakdown of cases was 7 students, or 13%, 18 staff, or 35%, and 27 parents, or 52%. The way the cases were found was when a patient was symptomatic or had a contact with a known case, they were referred for PCR testing. That's how they had to be symptomatic or someone directly with them had to be positive. The index case we talked about was a staff member who worked for the entire preschool and elementary school staff and was present for all the meetings. They actually felt the school outbreak was a good opportunity to learn something from it and try to evaluate if children are asymptomatic transmitters of SARS-CoV-2. They felt children have a minor role due to the literature at that point in symptomatic cases. They felt that looking for anti-SARS-CoV-2 antibodies would be a good way to determine if students were getting asymptomatically infected, and if yes, to what degree. So the design I found fascinating. They want to do a contact-free field study. So they used a finger prick chromatographic-based IgM, IgG antibodies test. And they felt this could evaluate a large number of students and staff, and they could do it 8 to 10 weeks after the start of the outbreak. And Megan, you looked at this particular test, and what did you think about it?
Yeah, so one of the things that's really hard about the antibody tests that exist for SARS coronavirus 2 is that there's like 400 of them, and they all have different performance. They all look at different antigens of the virus. Some of them, I would argue, are maybe more helpful than others. And they all have different performance characteristics. But luckily, you can look all of these up through the FDA to see their specific sensitivity and specificity. So I want you to, whenever you're critically evaluating literature, look and see which antibody test they used and look up the attributes of that test because they are very different. So this one is the CellX Q-SARS-CoV-2 IgG IgM rapid test. It is a lateral flow test, much like a pregnancy test, something that you can do at home. And its target is the spike and nucleocapsid proteins of SARS coronavirus 2. The sensitivity is 93.8%, so not terrible, but not as good as some of the others that I've heard. And the sensitivity is a little bit lower than some others, which means that we might miss some patients who have antibodies because of the limit of detection. So it's possible that the positive predictive value is a bit less than some others. The specificity is pretty good. It's 96%. So this is probably a test that is more valuable at saying this is a true negative.
And their primary aim was to determine overall SARS-CoV antibody prevalence during the outbreak and characterized prevalence by grade level as well as school staff. Now, the school is in a metropolitan area, just so if you're wondering. It's about 7.1 million people in the area. That immediate community around the school has about 85,000 people. The school has 2,616 students, 14 grade levels, 318 staff members, and 195 teachers. So it's a big school in a big metropolitan area. Everyone in the school, staff and students, were sent an email inviting them to participate. If they wanted to, they sent their home address, and an antibody testing kit was sent to them with step-by-step instructions how to use it. They used Stata as the data analysis software, and they mostly used chi-square Fisher exact test. Now, of the kids who were sent and agreed, 1,224 children were contacted by email, 1,105 were interested, and 1,029 child parents signed consent and participated, which is a very high number.
I was
I don't.
amazed.
Yeah, I was shocked how many said yes. And then 20 or 1.9% were excluded due to invalid or indeterminate results. They did it the wrong way, maybe. And 1,009 were included in the analysis. So it's a very good number. Of the staff, also they did well. 318 staff were contacted by email. 272 responded and were sent packages. 240 completed the online consent process, of which 235 were included in the final analysis, which is 74% of the entire staff. So huge numbers of percentage-wise of their population really agreed to do this. Now, the overall positive antibody rates for students was about 10%. 9.9% were overall antibody positive. For staff was 16.6% of the staff were overall antibody positive. High school students had a lower positivity rate compared to younger student levels. In the students, we said the antibody levels were more likely to be positive if you were younger. They had an increased PCR positive rate. They were more likely to self-report contact with one or more confirmed cases compared to the seronegative colleagues. It sounds likely it sounds like they had people, both students and the staff, declare the presence of any symptoms since the start of the outbreak. So they had people almost keep like a symptom log or diary. And overall, 490 of the students and 171 of the staff declared the presence of one or more symptoms since the start of the outbreak. In kids, abdominal pain and fever were more common among antibody positive patients. So 21% had abdominal pain and 17% had fever compared to antibody negative. And after they removed the PCR positive kids, the difference still remained and was significant. And they went through all of the symptoms. And here's one of the things that struck me about the paper for kids is that their symptoms. I remember the paper from China talked about abdominal pain, diarrhea, and vomiting was a little bit more common in kids than they felt it was otherwise. But the symptomatology, so the more common symptoms was headache, again, rhinorrhea, weakness was very common, abdominal pain, sore throat, in students who were positive for antibodies. And those who were negative antibodies actually still reported those symptoms at pretty good numbers. So overall, people were having symptoms. 52% who were negative for antibody reported no symptoms whatsoever. But headache, rhinorrhea, weakness, abdominal pain seem a little bit atypical for what you were seeing for COVID-19. Is that right?
I think the reports on this are really variable. So the biggest report to date is the Perry article from the New England Journal that was the essentially descriptor of the Italian study where they reported 100 patients, children patients with acute SARS coronavirus 2, but they also reviewed some of the data from China and from the United States. And in their study, GI symptoms were not a predominant symptom either. They were somewhere in the less than 20% of patients range, which would fit with this.
Yeah. So antibody positive students were distributed across all grade levels in the school, but were significantly less common in high school students. And there was a significantly greater number of teachers that were antibody positive and or had a history of a positive PCR in preschool compared to other levels, which didn't surprise me. Preschool kids aren't as good as covering their mouth, sneezing, all of that. So I kind of thought, I expected the preschool teachers to have a more issue.
It's just hard to know who brought it there first. But I think one of the things that you have to be careful about with this paper is the preschool had 13 positive teachers. The high school had 2 positive teachers. So when we think about the percentage of students that had positive antibodies, there's a confounder. So the outbreak dynamics were probably different in the preschool classroom than they were in the high school classroom. So it doesn't tell us about which children seroconvert and which children don't. It might just tell us more about what was going on in their classroom.
In their classrooms. Okay. And then antibody positive children had an average of 1.8 contacts with a confirmed PCR COVID-19 case. Antibody negative children had 1.4 contacts, and the p-value was significant there. And the most common COVID-19 contact in antibody positive versus negative children was their teacher. And interestingly, headache, again, we said was the most common. Their overall conclusion was, unless I'm remembering this wrong, that this can pass, and the antibody positive rate of roughly 10% in kids is what we have seen in some of the CDC studies or the studies in America, like in, I forget which state had a 10% positivity rate, but I found it to be an interesting paper.
I think it was New York City that you're talking about. I might be wrong, but I think that's where it was in that CDC study. The thing that's a little bit tough about the antibody tests and the antibody reports is that not every antibody test is created equal. Right. And there's been some evidence describing that people with more severe disease produce higher titer and longer lasting antibodies than those who are mildly or asymptomatically infected. So this, doesn't get at that very much at all, but it does make you wonder about if we might be missing some children because of their mild disease based on antibody-based testing. It's just another thing to think about.
And we don't, as of yet, know if someone has a mild disease and develops antibodies, how long those antibodies will last versus somebody with a severe disease.
Correct. And I want to remind the listeners that antibodies aren't the entire story when it comes to your immunity either. So you're also developing cellular T-cell immunity during the time of infection. And it's unclear, that is definitely harder to measure in the lab, but it's unclear kind of which components are going to be more beneficial for long-lasting immunity in this case.
And that was part of, we never mentioned pharmaceuticals on the podcast, but AstraZeneca in Oxford University had that big press release earlier this week talking about their vaccine created T-cell response and antibody response, which they felt was very favorable. It got a lot of press for it.
They certainly did. We've got a lot of vaccines out there. Maybe that'll be your next topic is the corona vaccines and
I'm going to need a lot of help with that one. All right. So that's this paper we've just gone through. And the next one, we're moving to another part of the world. Contact tracing during coronavirus disease outbreak in South Korea in 2020. This is by Park et al. This is released by the CDC, and it's supposed to be published. It's volume 26, number 10 in October 2020. So now this comes off as a report of more epidemiologic data from South Korea. They have a very robust public health system, and they have some analysis in addition to this. I want to read this part out loud because I'm going to read it verbatim, struck me as how thorough their contact tracing was. They identified an index case as the first identified laboratory confirmed case or the first documented case in an epidemiologic investigation within a cluster. Contacts in high-risk groups, household contacts of the COVID-19 patients and healthcare personnel were routinely tested. In non-high-risk groups, only symptomatic persons were tested. Non-high-risk asymptomatic contacts had to self-quarantine for 14 days and were placed under twice daily active surveillance by public health officials. So somebody either, I'm assuming, called. I don't think they showed up at the house. Twice a day, looking at the non-high-risk asymptomatic contacts, which was that's amazing.
they monitored 59,000 contacts.
Yes.
It's like an army of people would have been required to do this study.
It's a real testament to their public health system. It's phenomenal. Now, what they did was group index patients by ages every 10 years, 0 to 9-year-old, 10 to 19-year-old, 20 to 29-year-old, 30 to 39-year-old, et cetera. It's above 80. And what they did say that I tried following because they could not determine direction of transmission. They calculated the proportion of detected cases by the equation of number of detected cases over the number of contacts traced. I have to be very honest with you, I didn't quite get that.
Well, and this isn't exactly my area of expertise, so I'm not sure if that is a standard in the field or kind of how to assess that critically.
But they monitored, like you said, 59,073 contacts of 5,706 COVID-19 index patients for an average of 9.9 days after SARS-2 infection was detected. Now, of the 10,592 household contacts of the index patients, so people who live with them, overwhelmingly, so of the index contacts, 20 to 29-year-old was 3,417 or 32.3%. 50 to 59-year-olds was 19.3%, and 40 to 49-year-olds 16.5%. A total of 11.8% of household contacts of index patients had COVID-19, and in the households with an index patient who's 10 to 19 years old, 18.6 with a 95% confidence interval of 14 to 24% of contacts had COVID-19, and that was the highest rate. And the lowest rate of the household contacts with an index patient 0 to 9 years old of positive household contacts was 5.3%. So the 0 to 9-year-olds had the lowest rate of, am I reading this correctly?
You are, but this is a place where it's really important to look at the confidence intervals. So even though they make that conclusion, numerically it's true, the 10 to 19-year-old had 18.6% positive, but the confidence interval was 14 to 24%, which encompasses a lot of the other age intervals. So it's really difficult, I think, to make a conclusion about a comparison between that age group and some of the others. However, it does not overlap with the 0 to 9-year-old age group, which just has a slightly lower confidence interval. So 5.3% positive, 1.3 to 13.7 is the confidence interval. So it's just below the cutoff. But those little kids interacted with fewer people.
You would think they did. So it's interesting that, and then for most age groups, they said COVID-19 was detected significantly more in household than non-household contacts. And for non-household contacts, the detection rate was 1.9%. They talked about their limitations. They said a number of cases might have been underestimated because all the symptomatic patients might not have been identified. But this paper got a ton of press because it said 0 to 9-year-olds can pass it, 0 to 9-year-olds can't really pass it, 10 to 19-year-olds can pass it as much as adults. Is that what you took from this?
I took from this, I think my biggest conclusion, and this goes kind of with common sense, is that household contacts are infected much more frequently than non-household contacts across all age groups. And that probably just comes down to the amount of time you spend in the same space with an infected person. You know, you're watching Hamilton on the couch with the people in your house, and you're not doing that with the people that you encounter out in the world these days. So I think that definitely was a strong conclusion. Uh, it's a lot harder, I think, to make conclusions that those young people cannot transmit disease, because in the 0 to 9 age group, there were 2 non-household contacts that were infected. And in the 10 to 19 age group, again, there were 2 non-household individuals that were infected. So I think that the conclusions about the differences between the younger kids and older kids was a little bit of a stretch.
Yeah, I think that's the bulk of and everything we've talked. We've talked about 4 or 5 papers already, and it's always been the same kind of thing. It's interesting that they did this. Some of it was very hard to do, but does it answer the question, are kids good or bad spreaders of COVID? I feel we don't have an answer yet to that question. We don't really know, and only time will tell us. Do you agree?
I completely agree. I think we have evidence that it's possible that kids can spread, but we don't have definitive evidence that tells us if they're better at it or worse at it than adults.
We know they seem to do better when they get the virus. They don't have nearly the case fatality rate. They don't nearly have as bad, overwhelmingly issues with the virus, but we don't know how well they spread it.
And when we think about opening schools, we have to think about if a child gets infected, even though they might not have too many issues with the acute infection, they could infect their grandparents, they could infect their neighbor that has a kidney transplant. We just have to think about that they're still possible as vectors in the community.
Now, there's one other paper that was just in the New York Times I wanted to go over. I'm going to warn our listeners. This is the paper in Science from June 26, 2020, by Zhang et al., called Changes in Contact Patterns Shape the Dynamics of the COVID-19 Outbreak in China, volume 368, issue 6498. There's a lot of complex math because they do statistical modeling here that I am not an expert in. So we're going to go walk through it as best we can, because some of what they did that I do understand, I found interesting in how they did the contact surveys. So this paper discusses how the researchers developed a mathematical disease transmission model to disentangle how transmission is affected by age in the biology of COVID-19 infections and the altering of mixing patterns owing to social distancing. And they also project the impact of social distancing and school closures on COVID-19 transmissions. To do this, they performed 2 contact surveys in 2 cities, Wuhan and Shanghai. And the surveys were conducted from February 1st, 2020 to February 10th, 2020. If you remember, this was the peak viral transmission in those cities. So these cities had really high levels at that time. Participants in both cities were asked to complete the survey describing their contact behavior. So how many people they came in contact with each day. And then they analyzed a total of 1,245 contacts reported by 636 study participants in Wuhan, and 1,296 contacts reported by 557 participants in Shanghai. Now, contacts were defined as either a 2-way conversation involving 3 or more words in the physical presence of another person, or a direct physical contact like a handshake, which was nice that they defined. Now, in Wuhan, the average number of daily contacts per participant, well, they also compared. So in Wuhan, they asked them to do that compared to December 24th, December 30th. They did a second contact survey to look at how many contacts they had at both times, because in February, they had locked everything down. This was post-lockdown. In Shanghai, I believe because of SARS-1 or the avian flu or something, they already had old contact information for Shanghai from back in 2017, 2018. So they used that as the reference point. So what they found was in Wuhan, the average number of daily contacts per participant was significantly reduced from 14.6 daily contacts for the baseline period back in December 24th, December 30th, to 2 during the outbreak period when people locked down. And for Shanghai, it was similar, it went from 18.8 to 2.3, which that part makes total sense. If you lock everything down and you ask people not to go in contact with each other, they don't go in contact with each other, and they do exactly what you tell them to do. So that was fine.
It's very similar to what they were doing with some of the cell phone geo data at the beginning of the outbreak in the US, and would show an area pre-contact or pre-lockdown and post-lockdown, and with similar sorts of results that people really listened to the instructions in the beginning to stay home.
Yeah, it was nice. Then they had a lot of these contact matrices, which basically talked about the age mixing, and it said that age mixing occurred more before lockdown and less after lockdown, meaning adults mixing with kids and kids mixing with adults, all the ages together, which they were nice to look at, but I didn't understand the math behind them. And then essentially after the lockdown, the only age mixing was at home, within a household. First, they found the susceptibility to SARS-CoV-2 infection increased with age, which one of the things they said. Younger ages had a lower risk of infection, individuals' ages. So younger age, they put at 0 to 14 years old, and older, they put at 15 to 64 years old. So we kind of have talked about that. Then they used a predictive mode and found that the R naught significantly decreased in Wuhan and Shanghai after the lockdown and social distancing, which they attributed to decreased age mixing, meaning if people weren't mixing with everybody, and especially kids not mixing with adults and adults not mixing with kids, the R naught for SARS-CoV-2, which we've talked about in this podcast, is roughly between 2 and 3 in most studies, in an uncontrolled environment. With the social distancing measures, when implemented early, they felt that the R naught decreased to under the epidemic threshold, and then the epidemic could not take off in a location where that happened. Then they modeled to estimate the impact of preemptive mass school closures. And they state school closures caused the mean peak of daily incidence to decrease by about 42 to 64% in that range. And they said this may not in and of itself stop the pandemic, but it could save lives and slow it down. So they attributed the age mixing because of school, which is where age mixing occurs. Kids of all ages get together, adults are there, parents go in to be the parent monitor, the home monitor, whatever. And so they felt, using their mathematical modeling, that you could decrease the mean peak incidence of an epidemic from SARS-CoV-2 by about 42 to 64%. So it's interesting. I think it tells us what we've seen. What we have seen is that when we were on lockdown, children's hospitals got less busy all over the country. There were decreased admissions. Because again, if kids aren't together in school, they're not coughing and sneezing on each other. They're not in sports slobbering on each other on accident. None of that stuff's happening. So they pass viruses less. And so when viruses get passed less, SARS-CoV-2 gets passed less. Is that a fair assumption, Megan?
Yeah, I think that's great. I'm also not an expert on this type of modeling, so I can't really critique those methods, but I think it tells us that viruses don't exist in a vacuum. They need human hosts in order to survive and to replicate and to pass on one to another. And it teaches us or reminds us that the R naught can change based on human behavior. Which when we're not interacting with as many people, the replication number of the virus is going to be less.
So after reviewing all this data, I am no more clear now than I was before reviewing all this data as to how good kids are as spreaders of COVID. Will school closures work or they not work? Will they not work in certain locations? It's hard to really say.
I completely agree. It's really difficult to make decisions based on the data that we have. I think probably going forward, as different areas make different decisions about the opening of schools, is probably how we're going to learn more about the transmission dynamics of kids in SARS coronavirus 2.
Now, earlier in the week, there was a leaked document to the New York Times, which was like a 69-page CDC document. What it was supposed to be was it was supposed to be instructions for schools, both elementary, preschools, and colleges detailed instructions on how to open, what to look for, who to test, what teachers should do and say. I looked through 30 pages or so of it. It was very thorough, very nicely done. But one of the things they say in there is it needs to be an individual decision based on your community and your public health. So Allegheny County will be different than Houston and Texas because of the differences in viral spread. We're on
Yeah.
our way down, thankfully, after we peaked recently, but some places are still on their way up.
And I think it's going to involve a lot of risk mitigation strategies. I mean, we take risks every day. You get in your car, you drive to work. Sometimes before COVID, you went on airplane trips. All of these things come with an inherent amount of risk, and it's going to be up to the individual family what risk is right for them. So I think in the schools, the best that we can do if we're opening them is to try to decrease classroom sizes, try to increase the distance from student to student, require masks, enforce hand hygiene. We can do all of these things to mitigate risks, but we're also going to have to be really vigilant about if someone is ill, they should not be at school. And also should have a virtual option for kids that maybe are awaiting test results but are feeling well enough to participate. And I think the whole system is going to have to be very flexible and responsive to data, because if we start seeing outbreaks in schools, we're going to be able to react to that really rapidly to keep as many people as we can safe.
And that's the goal, because again, we don't yet know how important schools are for the pandemic in terms of spreading the virus to people who are more susceptible than kids.
Yeah. And since there's been school closures, it's not like there have been a lot of interactions of children out in the community for us to learn that any other way.
Now, Megan, before we let you go, I want to ask you this question. There was a whole hullabaloo with the WHO, and 239 scientists, I believe, wrote a letter asking to discuss more about how the virus can linger in the air and spread that way than the WHO was admitting to. Did you read that? Do you agree with them, or what was the issue with that?
I think the thing that gets a little bit complex is we think about how viruses spread mostly as contact. So I touch something and that's how I acquire a transmission. Respiratory droplet from one person to another, or airborne. Best kind of example that I have of airborne is measles. So it can linger in the air for a very long period of time. And one of my friends recently talked about it as like walking into a cloud of perfume. So if the perfume is still there from an infected person and you walk through the cloud, then you would have a high chance of being infected. I think as a scientist on this topic, I would never say never when it comes to things like, is it possible that some percentage of the time there is airborne transmission? I think it probably is. But I do think that for this virus, as for many other respiratory viruses, the primary mode of transmission is from respiratory droplets, which is why wearing a mask to contain your own respiratory droplets and to keep them from getting on surfaces and on other humans is really one of the best things that we can do as we're out and about in the community to stop the spread.
Well, I couldn't agree more. Now, we talked about a lot, Megan. Is there anything we didn't discuss that we should?
With this virus, Tony, there's always more to discuss, but I think that we've done a good job for now. Hopefully the listeners agree.
Hopefully, and for those of you listening, we did our best. There's a lot of data out, and again, this whole pre-publication is important to get data out, but it does create some papers that will likely change with peer review because of the way it's presented, which complicates our ability to review it. But this is the data that's available. This is the first time we've done an episode where we really don't have an answer to the question we started out with, but that's what's available. So we're gonna get you out of here on this, Megan. Thank you very much for joining us again. We really appreciate your time.
Oh, happy to be here, Tony. Thanks so much.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.